You know, chronic liver disease can be a really sneaky thing. It often works in the shadows, but one of its complications can turn a stable condition into a life or death emergency in an instant. Today, we're going to explain exactly what that is and why it's so incredibly dangerous.
So, let's just get right to it. What is one of the most dangerous complications of liver disease? Well, the answer is a variceal bleed, and it's a direct result of something called esophageal varices. In this explainer, we're going to break down exactly what they are, why they form, and how doctors fight back.
To really get a handle on varices, we first have to understand the plumbing problem that causes them. And honestly, the best way to picture it is with a simple analogy.
So, what are we talking about here? At their simplest, esophageal varices are just swollen, fragile veins in your food pipe, the esophagus. But here's the most crucial point. They aren't the disease itself. They're a massive red flag, a symptom of a much deeper issue happening in the liver.
This analogy just nails it. A healthy liver lets blood flow through it easily, like a wide-open river. But cirrhosis, which is severe scarring of the liver, acts like a giant concrete dam. It blocks the normal flow of blood coming from your digestive system through a huge vessel called the portal vein. And when that main route gets blocked, the pressure upstream just skyrockets. This is a condition we call portal hypertension.
And this pressure buildup kicks off a very predictable chain reaction. First, the liver gets scarred. Second, that scarring blocks blood flow. Third, the pressure in that portal vein builds and builds. Fourth, the blood, which is desperately trying to get back to the heart, is forced to find detours, these little side roads or collateral pathways. And finally, the delicate veins in the esophagus become one of those pathways, and they simply were not built to handle that kind of pressure. They swell up, they get fragile, and they become varices.
But here's the catch. Not all varices burst. So the big question for doctors is, how do you know which ones are a ticking time bomb? Well, it's all about measuring that pressure and looking for very specific warning signs.
And this is the critical number. When the pressure difference, the gradient, in that portal vein system climbs above 12 millimeters of mercury, the risk of those fragile veins rupturing becomes significant. The ticking of that clock gets a whole lot louder.
So when a doctor performs an endoscopy, they're basically a detective looking for clues. They're asking, are the varices large? Do they have these things called red whale marks, which are basically visual signs that the vein walls are stretched paper thin? And, of course, how severe is the underlying liver disease itself? All these factors together help them predict the risk of a rupture.
All right, so we've seen the warning signs, we've heard the ticking clock, but what happens when that clock hits zero? What happens when the dam finally breaks and one of those fragile varices gives way? That's the crisis.
I really can't overstate this. A variceal bleed isn't just serious, it's a code red, 5-alarm medical emergency. It has a high mortality rate, and it means the clock has just run out.
And when this happens, you see two classic and frankly pretty terrifying signs. First, hematemesis. It's a technical term for vomiting blood. It can be bright red and fresh or look like coffee grounds if it's sat in the stomach for a bit. The second sign is melena. This is when stools become black and tarry because of all the digested blood passing through the intestines.
When a person loses a large amount of blood that quickly, their body just goes into crisis mode. It's called hypovolemic shock. The heart starts racing to try and compensate, but the blood pressure just plummets. Vital organs stop getting the oxygen they need. And this is what makes a variceal bleed so deadly. It's not just the blood loss itself, but the complete systemic collapse that can follow.
So, in the face of this kind of crisis, how do medical teams fight back? Well, they have an amazing emergency toolkit, and it's broken down into 3 key strategies: preventing the bleed in the first place, controlling it when it happens, and then stopping it from ever happening again.
The absolute best strategy is always prevention. It's called primary prophylaxis. Every single person diagnosed with cirrhosis gets screened with an endoscopy. If varices are found, doctors can prescribe beta blockers to lower that dangerous pressure in the portal system. And for patients who can't take the meds or are at super high risk, doctors can proactively go in and place tiny rubber bands on the varices to choke off their blood supply. Now, if a bleed actually happens, it is all hands on deck. This is the emergency response. The number one priority is resuscitation. That means getting IV fluids and blood back into the patient. At the exact same time, they're given powerful drugs to constrict blood vessels and drop that portal pressure fast. Antibiotics are also critical because the risk of infection is sky high, and giving them actually improves survival. Then, as soon as possible, an urgent endoscopy is done to find the bleeder and stop it, usually with more banding. Okay, so once a patient survives a bleed, you might think they're in the clear, but that's not the case, not even close. The risk of another bleed is incredibly high, somewhere around 60%. So the standard of care is an aggressive combination therapy. Beta blockers to keep the pressure down, plus repeated banding sessions every few weeks until all the dangerous varices are gone. And if that still doesn't work, it's time to consider a more powerful intervention.
And that brings us to the two main rescue therapies. We've talked a lot about banding, that's the local fix. The TIPS procedure, on the other hand, is a much bigger deal. A radiologist actually goes in and creates a new channel, a shunt, right through the scarred liver. This physically bypasses the blockage and reroutes blood flow. It dramatically reduces portal pressure, but it does come with its own set of risks.
So you can see, managing varices isn't a one-and-done kind of thing. It's a continuous process. It's about understanding that even when the immediate threat is gone, the underlying problem, that dammed-up river, is still there.
And that brings us to what might be the single most important takeaway from all of this. It's this idea right here. You can ban the varices, you can lower the pressure with drugs, you can even build a new channel through the liver. But at the end of the day, a patient's survival depends on the health of the liver itself. The varices are just a symptom of a failing dam.
And if you want to see that in black and white, this data makes it brutally clear. The Child-Pugh score is just a way to grade how well the liver is functioning. If a patient has a bleed, but their liver is still in relatively good shape, that's class A, their 1-year survival is nearly 100%. But if they have severe end-stage liver disease, class C, that number plummets to around 45%. It all comes back to the liver.
Which brings us to our final and most crucial point. We can manage the flood, and we can patch the leaks. But the only real solution is to address the health of the liver itself. The varices are a terrifying symptom, sure, but the most important question we can ask is always this: what's causing the dam to break in the first place?